Bismillahirrahmanirrahim. Today I'm going to start your next topic regarding the rectum, anatomy of the rectum, and the different diseases of the rectum. Today my lecture is about the surgical anatomy of the rectum. Now, the learning objective, the purpose of this lecture is that at the end of this lecture, the student should be able to understand the anatomy of the rectum so that we can later on associate the anatomy with its relationship to the surgical diseases and treatment. Rectum is basically a part of the colon. Rectum begins where the tinea coli of the sigmoid colon joins to form a continuous outer longitudinal muscle layer which is at the level of sacral promontory. Here you can see it is the beginning of the rectum. These are the tinea coli. You can see tinea coli. They are joining to form the continuous outer longitudinal muscle layer of the rectum. This is rectum. So rectum is without tinea coli. This is one identification point for the rectum. Now this is the distal part of the large cat. As you can see, when we count the different parts of the colon, it is the distal part of the large gut and it is the pelvic part of the alimentary tract. The hemirectum is about 12 to 18 centimeter in length. So the length of the rectum from here to here is about 12 to 18 centimeter in an ordinary adult. Before going to the different aspect of the surgical anatomy, I would like to tell about the embryology of the rectum, how it develops embryologically. Now the embryological hindgut forms the upper rectum. So the rectum, development of the rectum, embryological origin of the rectum, it has two parts. The upper part of the rectum, which forms from the hindgut, while the lower rectum is derived from the cloaca, and this is surrounded by extraperitoneal connective tissue. Now the primitive gut tube is suspended dorsally by a mesentery throughout its length to form the mesorectum. Mesorectum, that is tissue around the rectum, this embryological origin. The muscular layers of the rectum are derived from the mesenchyme muscles, the muscles part of the rectum. Upper part of the lining of upper rectum is derived from the endoderm. Muscular layers of the rectum, they are derived from the mesenchyme that accompanies the endodermal part of the enoderm, with the inner circular layer preceding the outer longitudinal layer. Keep in mind, and this occurs in the 7th week of embryonic development. The levator ani muscles and external anal sphincter muscles, they form from within the surrounding mesenchyme, and they grow to make contact with each other and with bundles of smooth muscles from the outer longitudinal layer of the rectal wall. A layer of undifferentiated mesenchyme which separates the rectal muscle layer from the levator ani muscle and the muscle layer of the future anal canal. So this was about the embryology development of the rectum. Now if we go on to the gross anatomy of the rectum, its location, it is located in the posterior part of the lesser pelvis. This is posterior part of the lesser pelvis. So pelvis we usually divide into a major pelvis and a minor lesser pelvis. It rectum is located in the posterior part of the lesser pelvis. It is in front of the lower three pieces of sacrum and coccyx. Here you can see these are the three pieces of sacrum, and this is coccyx, and this rectum lies in front of that. So what is the extent of the rectum? It begins at the rectosigmoid junction. Rectosigmoid, where sigmoid colon ends and the rectum begins, which is at the level of third sacral vertebra. It ends at the anorectal junction, which is about 2 to 3 centimeter in front of and a little below the coccyx. Here you can see this is coccyx, and just below that this is anorectal junction. So it ends at the anorectal junction, which is about 2 to 3 centimeter in front and a little below the coccyx. If we talk about the course of the rectum follows the curve of the sacrum. If we see the sagittal section of the pelvis, we can see rectum follows the curve of the sacrum, which is concave inside, and it ends at the anorectal junction, as I told in the previous slide. Muscle sling, which is puborectalis muscle, this encircles the posterior and lateral aspects of the junction, creating and this junction is anorectal junction. So this sling creates the anorectal angle, which is normally about 120 degree. So this puborectalis muscle, which is in the form of a sling, it creates an angle at the anorectal junction, which I'll tell you later on that it has a function in the continence of the fecal matter. Now the course of the rectum within the hollow is, firstly it goes downwards and backwards, then it goes downwards, and in the lower part, third, it goes downwards and forwards. So this is the course of rectum in the minor pelvis. If we talk about the parts, then curves, peritoneal reflection of the rectum, they are important. You should know. The rectum has three lateral. If we talk about the curvatures, rectum has three lateral curvatures. The upper and lower curvatures are convex towards the right side. Keep in mind. And the middle curve is convex to the left. So in an upper 1/3 and the lower 1/3. In a coronal section, this curve is towards the right. It is convex towards the right side, and the middle one is convex. The curve is convex towards the left side. We usually divide rectum into three parts, equal parts, which is upper third, middle third, and then the lower 1/3. So we divide the rectum into three parts. The upper third is mobile, and as far as the peritoneal covering is concerned, peritoneal reflection is concerned, it has a peritoneal covering. This peritoneum covers the upper 1/3 of the rectum interiorly and laterally. So the upper 1/3 is covered by peritoneum, whole of the interior aspect and all the lateral aspect, not the posterior, which is in the hollow of the sacrum. The middle 1/3, where the peritoneum, here peritoneum covers only the interior aspect and a very small part of the lateral surface. So basically, middle 1/3 of the rectum covers only the interior. In here, the peritoneum covers only the interior aspect of the rectum. The low one third is extraperitoneal. So this part of the rectum, we usually call it extraperitoneal. It lies deep in the pelvis. It is surrounded by fatty mesorectum, and it is separated from the adjacent structures by facial layers. These are very important facial layers, and I'm going to tell about in the next slides. So the lower, upper one third and the middle one third, they are within the peritoneum, and the low one third of the rectum is extraperitoneal. Keep in mind, this is very important in many aspects. Affections like injuries may we count this best, whether the injury is extraperitoneal, whether it is intraperitoneal. So basically, these parts of the rectum which make this decision. Lower third injury is usually extraperitoneal. So fascias, we are talking about the surrounding, there are fascias. The low one third of the rectum is separated by facial condensations. Around low one third, there are facial condensations. There are fascias around the low one third. These fascia, anteriorly it is called fascia of Denonville. The posteriorly, it is the Walder's fascia. So these two important named fascias, they are important, and their significance is they play a role in the spread of the cancer malignancy of the rectum. Fascia of Denonville, which basically this is named after a French anatomist and surgeon Charles Denonville. It is after his name. It separates the prostate and urinary bladder from the rectum in males. So in males, it is anterior, fascia Denonville. It separates the prostate and the urinary bladder from the rectum, the lower one third of the rectum. The structure corresponds to the rectovaginal fascia in the female. Also, there's a difference between male-female pelvis. So in female, rectovaginal fascia, this structure corresponds to that. Now, fascia of Denonville, this is rectoprostatic fascia. Fascia of Denonville, it also inhibits the posterior spread of prostatic adenocarcinoma. So it's a strong layer, helps in this to prevent the spread of the prostatic cancer. Therefore, invasion of the rectum is less common than is invasion of other contiguous structures because of this fascia of Denonville. Here you can see this is cut fascia, incised fascia. This layer on this sagittal section, you can see this cut here. It is between, this is prostate, the urinary bladder, and this is behind this fascia of Denonville. Now, what is Walder's fascia? This rectum is separated from behind by another facial layer, which is Walder's fascia, a very strong layer. It separates it from the coccyx and the lower two sacral vertebra. Here you can see this is fascia, Walder's fascia. This one. Here you can see this layer, fascia of Walder's fascia, which separates the rectum from behind this the coccyx and the lower two sacral vertebra. These facial layers are surgically important. These two fascias, they are surgically important as they are barrier to malignant invasion. So in that sense, it is their significance. Another aspect of surgical gross anatomy of the valves is valves of the Houston. Rectum has valves of Houston. When we do proctoscopy, when we go inside the rectum while doing sigmoidoscopy, colonoscopy, we see these valves of Houston. These are basically transverse folds of rectum, also called Houston valves. They are semi-lunar transverse folds of the rectal wall that protrudes into the rectum. So, what are these Houston valves? These are transverse folds of rectum, transverse folds of the rectal wall that protrudes into the rectum. And this we can see while doing proctoscopy, sigmoidoscopy, colonoscopy. Their use seems to be, so what is their use? Why these valves of Houston? It's probably seems to support the weight of the fecal matter and prevent its urging towards the anus, which would produce a strong urge to defecate. So, in that sense, it helps. It prevents the its urging towards the anus. These valves of Houston. These folds are about 12 millimeter in width, and they are composed of the circular muscle coat of the rectum. Keep in mind, this contain the circular muscle coat of the rectum, these valves of Houston. They are usually 3 in number, sometimes even a 4th is found. So valves of Houston, here you can see, these are the valves of Houston. This here, upper one, this one is the valves of Houston, and this is the valve of Houston. So these superior rectal valve, middle rectal valve, inferior rectal valve. So you can see in this photograph these 3 valves of Houston. So one is located, the upper one is located, it is located in the, one is situated near the commencement of the rectum on the right side, a second extends inwards from the left side of the tube opposite the middle of the sacrum, and then a third and the largest and the most constant projects backwards from the fore part of the rectum, opposite the fundus of the urinary bladder. When a 4th is present, it is situated nearly about 2.5 centimeter above the anus verge on the left and posterior wall of the tube. So these are the valves of Houston. Now, as far as the relations of the rectum they are concerned, when we describe them, we have to describe them separately in male and female. So, what are the interior relations? Interior relation, when we talk about the interior male, they are different. In female, they are different. In male, interiorly, urinary bladder is there, seminal vesicles, ureters, prostate, and urethra. They come in the interior relation of the rectum. In female, the interior relations are pouch of the Douglas, then that is recto-vaginal, recto-uterine pouch. Anteriorly, then is the uterus, then is cervix, and upper part of the posterior vaginal wall. That comes as the interior relationship of the rectum in females. Laterally, in males, rectum has the relations there are lateral ligaments, middle rectal artery, obturator internus muscle, side wall of the pelvis, bony side wall of the pelvis, pelvic autonomic plexuses. They also come in the lateral relations of the rectum. In female, again, they are almost similar. Lateral ligaments, middle rectal artery, obturator internus, side wall of the pelvis, pelvic autonomic plexus, levator, and so you can see in male and female lateral relations, laterally structured, same structure they are there. Now, what are the posterior structures which lie posteriorly in the rectum? In male, posteriorly it is the sacrum and coccyx, loose areolar tissue, facial condensation, as I told you, superior rectal artery which runs and comes in the posterior relation of the rectum, then hypogastric nerves, These are very important when we do dissection of rectum and of procedure, anterior section, abdominopelvic section. Then they are very important when we are doing dissection in the hollow of the sacrum, these hypogastric nerves, because their injury can lead to some complications. Posterior, then they are located lymphatics. Similarly, female sacrum and coccyx, same relations as in males. Sacrum, coccyx, loose areolar tissue, facial condensations, superior rectal artery, hypogastric nerves, and lymphatics. So here we can see, if when we talk about the relations and structures around the rectum, male female difference only comes when we are talking about the interior structure which lie anterior to the rectum. Now, what is the blood supply? What is the blood supply? Arterial supply, we can count. There are three vessels. Predominantly, it is the superior rectal artery. It's the main arterial supply of the rectum. Keep in mind. So, the major arterial blood supply is from superior rectal artery. Now, what is superior rectal artery? It is the direct continuation of the inferior mesenteric artery. Here you can see this is the inferior mesenteric artery. It is here continuing as superior rectal artery. This is superior rectal artery. You can see that. This is continuation of inferior mesenteric artery. This is the main blood supply, arterial supply of the rectum. Superior rectal artery. Now, middle rectal artery is a branch of internal iliac artery. Keep in mind, it comes from this is, here you can see this is internal iliac artery, and the middle rectal artery, you can see it comes from the internal iliac vessel. Middle rectal artery is a branch of internal iliac artery. The third arterial supply is from inferior rectal artery. Now, the inferior rectal artery is a branch of internal pudendal artery. It is a branch of internal pudendal artery. This is inferior rectal artery, which comes from the internal pudendal artery, which runs in the Alcock's canal on the side wall of the pelvis. So these are three vessels. Now I again repeat, arterial supply of the rectum is by three vessels. Keep in mind, one is superior rectal artery, then is the middle rectal artery, inferior rectal artery. But keep in mind, the predominant main arterial supply is by superior rectal artery, which is a branch, and this is branch is basically continuation, direct continuation of the inferior mesenteric artery, and it comes in the posterior relation of the rectum. It runs in the posterior hollow of the sacrum. What is the venous drainage? When we say blood supply, another aspect of blood supply is venous drainage of the rectum. The venous drainage of the rectum parallels the arterial supply. So we can say superior rectal veins, middle rectal veins, and inferior rectal veins. The superior rectal vein drains into the portal system, and this is via the inferior mesenteric vein. The superior rectal vein goes into this drainage is into portal system, and which is how that, because it continues that inferior, it goes into the inferior mesenteric, it continues as inferior mesenteric artery, and inferior mesenteric vein, it's an inferior mesenteric vein which drains into the splenic vein, and splenic vein and superior mesenteric vein, they form the portal vein. So superior rectal vein, blood goes into the portal system. Middle rectal vein drains into the internal iliac vein. This is not portal system. Main arterial supply by the superior rectal artery, Main venous drainage by the superior rectal vein, which goes into the portal system. This is very important. You must keep in mind. The middle rectal vein and the inferior rectal venous drainage is into systemic veins. Middle rectal veins drains into the internal iliac vein. Inferior rectal vein drains into the internal pudendal vein and subsequently into the internal iliac veins, which is a part of the systemic venous system. Again, I repeat, this is very important. Main arterial supply of the rectum is by superior rectal vein. Main venous drainage of the rectum is by superior rectal vein, which drains into the portal venous system. A submucosal plexus, which is deep to the columns of Morgagni, forms the hemorrhoidal plexus, and this drains into the all three veins. Basically, when we will talk about the venous drainage of the anal canal, the hemorrhoidal plexuses, they come, and from there they go upwards and they drain into these three rectal veins. So that was basically submucosal plexus deep to columns of Morgagni, which are located in the anal canal. They form the hemorrhoidal plexuses, and they drain these hemorrhoidal plexuses. They drain into all three rectal veins. Lymphatic drainage. Again, this is very important aspect of the surgical anatomy of the rectum. You should be aware lymphatic drainage, because their significance comes when we are talking about the rectal malignant tumors, rectal carcinomas. Upper and middle rectum drains superiorly into the inferior mesenteric lymph nodes. Upper and middle rectum is basically these two thirds. They are a relation with the peritoneal. Lower third is extraperitoneal. So upper 1/3 and middle 1/3 of the rectum, that drains, lymphatic drainage is superior. So that goes superiorly into the inferior mesenteric lymph nodes. Lower rectum drains both superiorly, that it goes into inferior mesenteric lymph nodes, and also laterally into the internal iliac lymph nodes on the side wall of the pelvis. These they are lymph nodes located along the internal iliac vessels. So lower rectum drains into the superior mesenteric lymph nodes, but also this lymphatic drainage goes into the lateral wall, which is internal iliac lymph nodes. However, if the usual upwards routes are blocked, so keep in mind, it is the upward lymphatic drainage which is important. Main lymphatic drainage of the rectum is upwards, especially when we are doing tumors of the upper 1/3 of the rectum, middle 1/3 of the rectum. Its main lymphatic drainage is upwards into the inferior mesenteric lymph nodes. It is the low 1/3 which also drains into the internal iliac group of lymph nodes. So, if the usual upward routes are blocked due to tumor by these lymph nodes, sometimes they come blocked in advanced malignancy, then flow can reverse, which is mainly upwards. Now it can reverse. It is then possible to find metastatic lymph nodes on the side wall of the pelvis, along the middle rectal vessels, or even in the inguinal region. So in the lower 1/3 of the carcinoma of the low 1/3 of the rectum, when the upper flow is blocked, then there is a possibility that even the internal inguinal region, lymph nodes located there, they can sometimes become involved, that is along the inferior rectal artery. Here you can see the lymphatic drainage. This is the whole colon. You can see different types of lymph nodes, epicolic, then along the vessels. Ultimately, you can see going up to the paraaortic lymph nodes, following the superior mesenteric vessel and the inferior mesenteric vessel. These are the lymph nodes. So, epicolic group of lymph nodes, paracolic group of lymph nodes, then principal and the intermediate group, and ultimately they go into the paraaortic group. So, except the rectum, all the rest of the lymph node of the colon, they have four groups, starting from the epicolic, paracolic, intermediate, and the paraaortic. Here and from the rectum, it is basically the three group of lymph nodes. They drain upper zone, middle zone, and lower zone, as I talked to you about the lymphatic drainage of these parts of the rectum. So this you can see the lymphatic in this photograph. You can see the lymphatic drainage of the colon as well as the rectum and different parts of the rectum. They are basically described in this photograph. Now, if we talk about the nerve supply, sympathetic nerve supply of the rectum is from L1 and L2 fibers. The lateral column segments is L1 and L2, and they come through the superior rectal and inferior hypogastric plexuses. These sympathetic fibers, they come through the superior rectal and inferior hypogastric plexus. Their function is they cause vasoconstriction. They are inhibitory to the musculature of the rectum. When there is stimulation of the sympathetic nerve supply, they inhibit the musculature of the rectum. They are motor to the internal sphincter, motor fibers to the internal sphincter, inhibit the external sphincter, carry sensation of pain. So the pain cessation from the rectum, they go through the sympathetic nerve supply, which is from lumbar 1, L1 and L2 of the lateral sympathetic column of the spinal cord. Parasympathetic nerve supply of the rectum is basically from the sacral outflow. It is S2, S3 or S4 fibers. They pass via pelvic splanchnic nerves and the inferior hypogastric plexus to the pelvic or to the rectal plexus. So this is the root of the parasympathetic nerve supply, which is basically sacral outflow. It is from S2, S3 and S4 sacral segments. They pass via the pelvic splanchnic nerves and the inferior hypogastric plexuses, ultimately to the rectal plexus. The parasympathetic, these nerve fibers, they are motor to the musculature of the rectum. Sympathetic was, they were basically inhibitory to the musculature of the rectum. Sympathetic was vasoconstrictor. Parasympathetic fibers, they are inhibitory to the internal sphincter, while sympathetic were motor to the internal sphincter. So this you can see, so parasympathetic fiber, when they are stimulated, they inhibit the internal sphincter, and the parasympathetic fibers, they also carry sensation of pain and distension, which occurs in the rectum. So pain, it is also through the sympathetic as well as parasympathetic. Distension, sensation of distension in the rectum is through the parasympathetic nerve fibers. So this was all about the surgical anatomy of the rectum. Different aspects I have told you: embryology, gross anatomy, then the blood supply of the rectum, and the nerve supply of rectum. This was all about the surgical anatomy of the rectum, and it was the subject of the today's lecture. So if you have any questions about this topic, those questions you can forward to me in your WhatsApp group, and then I will respond in that group. Okay. Thank you.